So thank you very much. Our final speaker in this session is Brian Elbel from NYU. I don't know if I should try to, if I'll say read, yes. Well, COVID-19 vaccinations and school community resources, and unless you've changed the title.
That's pretty good.
There we go. I'll leave it. I think you want to present in the present mode.
How do I do that? Oh, wait. Oh, on here?
Oh, that was, yeah, she had it on, it was on.
Sorry.
He has a PDF, so it's gonna look a little bit different.
Oh, we'll put it on the screen, that's why. You put in full screen. Oh, I can't see where I'm at. So very pleased to be here. Thanks so much. Here with my co-PI, Alan Schwartz, who's here as well. Great. And yes, going to be talking to you about basically how to here. Let me just show you this. Start with this. This is our group. I said Amy's here. A really great set of collaborators, including notably folks from the Office of School Health at DOHMH/DOE, which is a joint office. So they're key collaborators in this work as well. And the basic goal here is to, I'm not going to read all of this, it's basically how did kids in New York City do during the pandemic and how did vaccination status change that? And then really kind of how does school and community resources matter as well. I can't see here, so I'm going to be turning around a little bit. I can see there too. So I think a really unique aspect of this project are the data that are available. So we're using something called the Student Population Health Registry, SBE, and this is basically all New York City public school kids taking their core education data and then linking it up with a whole bunch of other data around their health status as well. So New York City, pre-COVID had about 1 million kids in the public school system, a little bit less than that now. About 86% of kids in New York City attend public school, largely Black and Hispanic district, largely low-income households, right? So just to kind of give you a flavor for the kids that are there. These are the data, right? So our example of the data. So we have great data on their demographics that are reported by parents every year in the education files. We know where they live, we know where they go to school, and then we link up with that a whole bunch of stuff, right? You know, all the vaccinations they've got from our citywide immunization registry, Medicaid claims, Sparks' every inpatient and ED visit in the state that we can link up, you know, attendance, test scores, all that sort of thing. And then we also put a bunch of kind of neighborhood and school data in there as well to understand the influence of some of this also. So the main paper I'm going to tell you about today, and if we have time, I'll do a little bit of another one, is, you know, how did vaccination really matter for kids in the public school system? And I should say this is really driven by Eric Zhou, who is just finishing with us and starting a tenure track job next year at Mount Sinai School of Medicine. So we know from clinical trials that vaccines are really effective for kids, right? You know, 90% effectiveness in not infections, but for severe outcomes, going to the ED, being hospitalized, things like that. And the question is, how does that really play out in the real world, right? You know, is it different in a school context? Is there difference in when kids are interacting differently as the virus changes over time? And what about looking at things beyond these kind of pretty narrow set of health outcomes, education outcomes as well? So that's one of the things that we're going to do today. I think the real kind of value add here is looking at bunches of those outcomes and also being a little bit more thoughtful about, like, we can't do an RCT, right? This is not an RCT, but what we can do is try to find some interesting sources of variation that kind of can broadly mimic that. And what we're going to do is really look at this kind of threshold around, if you remember, 12 to 15-year-olds became eligible about 6 months before 5 to 11-year-olds. So we're going to take care of that. We're going to utilize that variation, right? And we're going to look at kids just 12, because again, big school district, we can do this, just kids 12 and a half compared to just kids who are 11 to 11 and a half. All right. And we do, I'm not going to be able to show it today. We do some nice balance tests to show that these are actually really similar groups. And then we can use this kind of framework that actually I'll show you is pretty lasting in terms of changes in vaccination rate over time to look at both education outcomes like test scores, absences, sick days, and then health stuff. Are they going to the doctor? Are they going to the doctor for COVID? Are they getting hospitalized for COVID? So this is looking at over time vaccination status. And if you look at the kind of blue line first, that kind of dotted line on the left is when the vaccines for 12 to 15-year-olds are released. You can see about 2 weeks after that, you know, because, or 2-3 weeks after that, because you had to get a delay between your first and second shot, we start seeing a pretty rapid increase in the percentage of kids who are fully vaccinated. They have both shots against COVID-19. and then it kind of goes and plateaus out maybe 6 or 8 months later than that. And then the second dashed line is when kids 5 to 11 became eligible for vaccination. And you see something similar. You see kind of it going up pretty rapidly and then plateauing again, kind of 5 or 6 months after that. The other thing to pay attention to is that there's a persistent gap, right, at steady state between kids who are in the kind of older age group and the younger age group, even after they've had a long period of time to be vaccinated. And that's really the variation that we're going to take advantage of here to try to look at some of these key differences without having the ability to do an RCT. So let me show you what that looks like, right? Kind of what does our first stage, if you will, look like here? And we basically see that and these are linear probability models. So there's a 37.4% chance of being vaccinated before the first day of school if you have, if you're in the early eligibility group, 12 versus 11-year-olds. 83 more days that you are in school while you're vaccinated, 29% difference in the number of days that you are fully vaccinated in school, and that kind of gap, percent ever vaccinated, 13%, is consistent, right, over time. So this is the variation that we're going to use there to look at some of these differences. So let's just kind of take a couple examples. So this is some event study work looking at if you are in that earlier eligibility group, your likelihood of having any outpatient visit over time. Like this is monthly level data. This is using Medicaid claims. And what we see is, pretty much no difference for quite a long time, right? Even after that first dotted line, the 12-year-old kids were eligible to get vaccinated, really no differences there as well. And then starting in about December, you do see some differences there where the early eligibility kids are actually going to the doctor, going to outpatient visits much less. That stays pretty consistent even if it doesn't get directionally the same, even if it doesn't get quite that same big magnitude. And then this is that 12 versus 11 early eligibility of having any COVID infection over time. Now, COVID infections coded from Medicaid claims, not great, but you still see some of those same things, right? You still see some of those differences there. And basically what we can see is that this is when the Omicron wave was coming through New York City. And so it very much mirrored the fact that this is when kids were getting sick, right? Is when we kind of saw some of that protection from COVID vaccine, which is sort of what you would largely expect here. Let me show you both kind of the intention to treat, the differences between the early age eligibility and then the local average treatment effect of uptake, really kind of using that early eligibility as an instrument. And if you look all the way at the right, you can kind of see like what percentage change are we talking about here for each of these outcomes. So 40% decrease in outpatient visits, 60% increase in COVID infection, again, with a kind of pretty narrow way we can look at it. 42% decrease in COVID-related outpatient visit. The CDC put together a code of things that are likely to be COVID-related if you kind of put a couple claims together. And so that's what we saw there. No change in ED visits, but essentially a reduction of a complete reduction of COVID-related ED visits, which absolutely mirrors what you saw in the clinical trials as well, where you saw that basically ED visits related to COVID almost went away there. So again, some pretty strong effects here that are potentially really meaningful. So just to kind of talk a little bit about some of the other work, we do have these really strong first stage effects. We can look at this in a couple different outcomes. We're not going to have tons of time to talk about today, but we did look at this for test scores as well. Now it's a little tricky because this is a year that was not a lot of kids were taking the state test, so we can't like hold too much to these data, but we did see some actually increases for math and ELA test scores, English language arts test scores for kids that were vaccinated, somewhere between 4 and 12% change in standard deviation here. So some like non-trivial effects here potentially, and we need to spend a lot more time kind of thinking about what is it that's potentially driving some of those mechanisms. We didn't see a change in absent visits, although our absentee data isn't great. But what we did see is a decrease in sick days. Kids going to the doctor on a day that they are supposed to be in school. So maybe that's a potential mechanism here as well. And as I showed you, kind of the outpatient visits and changes in COVID infections. Obviously you saw this is going to matter when community infection is high. And so that's when we saw the most impacts. We did see some differences by race, ethnicity, and borough of residence within New York City. But again, this is, COVID infections for Medicaid claims. This is just looking at one narrow age group that we have a nice identification strategy for this right around 12 group. And, some of the data were a little spotty because of the pandemic, particularly things like test scores. So that's what we have for you on vaccination. I want to talk just a little bit in the last few minutes on school opening and reclosing. Closing and reopening, rather, particularly thinking about things like mental health and achievement. I'm largely going to show you today a little bit of data we have on how often kids were in school to give you a sense of how the next stage we're going to do to kind of think about how that might impact some of their outcomes. So how did what we call mode of instruction, or how often kids were in school, change mental health outcomes, right, is one of the key kind of questions here. It's a little bit complicated, but basically this is showing you K through 5, 6 through 8, 9 through 12. And the kind of top red bar there is when schools closed for the pandemic in the 1920 school year, right? All New York City kids, public schools, like most, were remote during that period. And then you have the summer, that gray bar. And then the yellow, you have what's called the first wave of hybrid instruction. So parents could choose whether or not they wanted to send their kids back to school in a fully remote setting for all of the school year, or they wanted to do what was called hybrid or blended learning, where they spent a couple days a week, I'll show you some data on how often, actually in school, and the rest of the time was remote. And this is a choice that parents could make before the school year, and there are a couple other opt-in periods, those black periods across, that we can take advantage of as well. The other thing you'll notice is that you see there's some kind of differences when the bars go from yellow to red versus when there's hybrid, versus when all schools were remote because infection rates went up, and then versus when they kind of staggered when schools went back. So we do have some variation there we can take advantage of when, for example, K through 5 was most consistently in school. They only closed for a couple weeks when infections got really bad. There was a month or two gap before middle schools went back, and then another couple months after that before high schools went back. So that's some variation we can take advantage of as well. Just to give you a sense of who's going back, who's choosing this remote versus hybrid instruction, and this is the linear probability model predicting going back at all versus choosing that kind of hybrid blended learning instructions. And what you see there is that older kids, as compared to the excluded group here is K through 5. You saw that 6 through 8 and 9 through 12 were less likely to parents were less likely to send their kids back for in-person instruction. Asian, Black, and Hispanic were less likely to send their kids back for in-person instructions, with Asians being the least likely to do so. Males slightly more likely to be sent back for in-person instruction there. The COVID-19 case rate did matter a little bit, although not in the direction I could actually kind of argue this either way. More COVID cases in the community, you were slightly more likely to go back for in-person instruction, not a huge effect, but something. And the farther you lived away from your school, maybe you have to use public transportation to get there, things like that, slightly less likely to go back. So there are some differences here we have to be really kind of thoughtful about in terms of using some of this variation here. So this is a figure looking at going any in-person instruction during the school year by grade level over time, right? So you see kind of at the early stages, that first month, September, it was largely just the K through 5 kids that were going back at all during that month. And then you start seeing, all right, and in October, November, all of the kids were going back to some extent. And then in the kind of December, January, you see it's really only elementary school kids who are in school. And then starting again in February, you start sending the K through 5 back. And it really isn't until March when you start seeing high school kids coming back again because of when schools were reopening. You see big differences here and the likelihood of going to school at all based on grades. So it is very much true that the elementary school kids were going back more. This is the amount of in-person instruction you're getting, conditional on kind of going back, right? Conditional on being a kid who's hybrid or blended. And what you see there is that even for look at October, November, right? Even those months, even for kids who are going, they're not going 20 days a month, right? They're really only going 5-6 days. So even like in person here did not mean full on in-person instruction. You do see some weird quirks, like if you look at kind of January when high schools were basically closed, but you see a lot of high school kids going. That's because the only kids who were going were kids who had special needs in particular kinds of schools that needed to be there for different sorts of reasons. So this is the kind of variation that we're going to be able to kind of take advantage of a little bit and think about using some of the staggered return to school. Can we think about 5th versus 6th graders when they went back differentially? Can we think about 8th versus 9th graders? And the kind of outcomes we're going to want to look at here are mental health outpatient care, prescriptions for mental health things, ED visits for mental health conditions. And then we're also going to look at, for the next school year as well, how did that impact longer term attendance rate? How does it look about kind of use of mental health services? How do we think about test scores? So again, not perfect groups here, but I think even descriptively, it'll be really important to look at some of these differences. So that is it. Thanks so much.